Good afternoon, everyone, and welcome to this Royal College of Paediatrics and Child Health webinar on Shape of Training, where we will cover some key points in relation to upcoming changes to the curriculum for paediatrics and their potential implications for rotas, teams, and service provision. We are recording it to distribute to service leads around the UK to help bring this important conversation back into central focus. I'm Daniel Wayland, the now not so new Director of Education and Training at the College, and I'll be asking some questions to an expert panel, which consists of David Evans, the Vice President for Training and Assessment, who's been chairing this curriculum work, and Nicola J, the Officer for Workforce and Service Planning. So welcome both, and let's get straight on to the first question if you're ready. So this one's for David. COVID has understandably taken our minds off of this important area. So could you give us a helpful reintroduction into SHAPE and to Progress Plus?
Sure. Well, as people might remember in the dim and distant past, the original Shape of Training review, I think, was back in October 2012, 2013. And it asked colleges and training pathways to think about reforming their training pathway to make it more flexible, particularly for trainees, but also more responsive to the needs of patients. And we started off on this work over, probably about the last 4 or 5 years. And we decided really to move from our current 8-year 3-level training system to a 7-year 2-level training system. The first 4 years being core paediatrics, and then the second 3 years being specialty paediatrics. And that we think will be more flexible for trainees because there's only one division as you go up from core to specialty, and there's a number of other things sort of built within the pathway that should make it flexible and responsive. The other work we did, of course, is we reformed the paediatric curriculum, and we now know that as Progress, and that looked at, rather than defining lots of competencies, it defined more broader but more important capabilities. And this was driven by the GMC's requirement for us to incorporate their generic professional capabilities. And so that was the first part really of the reform of the training pathway. And the curriculum as it is now gives us a bit more flexibility because it's not defining set roles and set placements, but it's defining what capabilities the trainees need to have acquired by the end of their training. So we've sort of now, the next step really is to combine the two and move from our SHAPE ideas and the Progress ideas and bring them together. And so we're going to call this Progress Plus. So the next stage is Progress Plus, which is the implementation of SHAPE in training and the Progress curriculum together. And we're hoping to do that in the next few years. And we're planning implementation around the August-September changeover for the year 2023.
Thank you for that, David. In terms of trainees and trainers, how is this likely to help improve the training experience?
One thing it will do is, because the curriculum is now defining capabilities and not by set time in particular placements, it means that trainees should be able to progress through according to their capability rather than just merely time served. So I think it'd be more responsive to their learning needs and their abilities. So that's the first thing. The second thing, of course, is one of the headline figures is the fact that we've reduced the sort of indicative training time down to 7 years. And I think when you talk to trainees, there can be some mixed views about this, but broadly, those trainees who are quite senior are generally don't mind training and are quite, appreciate having lots of experience because they view it as preparing them for a good job application. But if you do talk to medical students in foundation years, they look upon the 8 years as a very long time, particularly when they compare it to some of the other training pathways. So I think having 7 years and also saying to people, we will recognise people's ability to move quicker through the system, that should make it more attractive to people coming into paediatrics. And I think that's what we desperately need at the moment.
In terms of that reduction from 8 to 7 years, Practically, what does that mean in terms of the year that's disappearing? What year is going, and what experience would normally be had in that year, and how are you going to accommodate that?
Yeah, so at face value, it's the ST5 year that's going. So to just describe the new Progress Plus pathway, the first 4 years is core paediatrics, and 3 years you'll be getting a general grounding and also being prepared to move on to tier 2 rotas. And the final year, ST4, which is still core paediatrics, you will be on the tier 2 rota. And you need to have got your full membership before you then move on into specialty paediatrics. And the specialty paediatrics will be 3 years, very similar to our current last 3 years of training, so years 6, 7, and 8. So in a sense, it's that ST5 year has disappeared. So it means that people don't have to fit into that fairly rigid level 2 training where they have to do a minimum of 6 months community, as 6 months neonatal intensive care, and 6 months pediatrics. There are capabilities that are required they need to gain before they move from core to specialty, and so some of those capabilities are applicable to neonatal units, so some of the practical skills, and some are very applicable to community placements such as safeguarding and those sort of things. But they're more generalizable and not dependent on specific placements. So it should give the training program directors more flexibility on how they place their trainees. And I think it will improve the efficiency of training and also improve the experience that trainees will have, particularly for those who know what they want to do, because they'll be able to move into that sort of area of paediatrics at an earlier stage.
So to bring in Nicola at this point, does that mean in reality there are less trainees available for tier 2?
So while that might initially appear to be the case, because it'll be obviously the ST8s that CCT earlier, I think as David just said, the expectation will be is that the ST4s are on the tier 2 rota. But increasingly across the United Kingdom, we know there are models of care where even the ST3s are on the tier 2 rota as well. So the hope is that with a competency-based training and where they get good experience and good training, which is also what the Progress Plus is about, then the hope is that these ST3 trainees will be able to progress to the tier 2 rota as well. But initially there may well be a gap that we need to think about how we manage that and who we need to help support those services. Again, the thought is that we have huge gaps in rotas at the moment, and if with Progress Plus we have better retention, then we may actually increase the number of people in the tier 2 post as well.
Just to go in on that point a bit more, you mentioned about attrition and retention. Do you think this is, alluding to some of David's earlier points, likely to help?
Absolutely. So the feedback that we've had so far is this is going to be influential on recruitment and retention for all the reasons that David's just said. If people are happier in their jobs, then they want to stay. You know, training, reduction in time should help support that. The increased flexibility should help support that. And also the better training. So doctors knowing that they're not just there for service delivery, but acknowledging the fact they're going to get better training and better training experience should all improve that retention. Thanks
for that, Nick. And David, back to yourself. In terms of the reduction of trainees, we talked about it in terms of tier 2, but if we move from an 8-year program to a 7-year program, one presumes that means there will be ultimately, eventually, less trainees in the system. So do you think that would be the case, and how do you think we would help manage that?
Okay, so if we are recruiting the same numbers that come in at ST1 and they move through the system, then what will happen is, because we're training them for less time, there potentially could be less trainees in the system. However, as trainees finish a bit earlier, there will be more people with CCTs coming out. So there will be the ability for us to look at creating jobs for some of those CCT holders. I think the other thing to say is that this won't be a sudden step change. It won't be a cliff edge, because when we transition into the new Progress Plus, what will happen is that people who are already in the last 3 years of training will stay in the last 3 years of training. that's very similar in both pathways, so the existing pathway and the future pathway. It will be the people who are around ST4 and would have started ST5 are the ones that are going to transition. And so we won't see any effect until at least 3 years from the implementation. So we're talking about 2026 for the first sort of effects of that. And then that will be mitigated by a number of things. One is, I think we are intending to give the ST4s and 5s some element of choice about whether they move into specialty training a year earlier than they were originally anticipating. And some might do that because that they know what they want to do, but others may have been dependent on doing some particular placement, and they want to do that placement before they decide to go into their last 3 years of training. And so I think giving people choice will also smooth that transition. And of course, we know, and Nick knows very well, about the other things that smooth those transitions, such as out of program experience, various leaves, and going less than full time. So I think that the step change will turn into a sort of a barely perceptible little hump, I think. The other issue is that when we planned this pathway with health education and the other statutory education bodies, we were told very clearly that it was not to do with a cost-cutting exercise. So if we are going to pay trainees for one less year, there will be some monies released, and that might be used in a number of different ways. And we're in the process of looking at those options and perhaps planning that on a more strategic level across the country. So you could potentially recruit more ST1s coming in, and that depends on our ability to recruit and also the supply for medical schools. And so some of that has gone up. But of course, you know, the focus is on where we need the medical primary care versus secondary care may change over the years. We could also use that money to improve the quality of training, and we can use the money to employ other healthcare professionals to support training within the pathway. So I think there will be impacts in terms of numbers, but any decrease will be mitigated. But the important thing is to start planning for that, so that you can utilize the new CCT holders that are coming out, and also potentially utilize some of the released budget, if you like, to support the training.
That's great. And following up on the back of that, and to yourself, Nick, in terms of the use of some of that funding from that envelope, I've been very interested since the start of learning about what the community's been doing in the round of PAs, physician associates, and ACPs, advanced clinical practitioners. Do you think there is a role for considering those now not so novel workforces in paediatrics?
Yes, absolutely. And I think we know across the United Kingdom, particularly in England, that there are many organisations that are embracing the different models of provision from ACPs and PAs, and they've been shown to be very effective. They work as part of a multidisciplinary team, and we know that having that team approach is really important to improve health outcomes, and also having a team that actually provides effective care. So having a full rota, having people in place, which is much better for children rather than having gaps in rotas as well. I think that, you know, we already know that we have deficiencies in rotas and deficiencies in the ability to provide care in the way that we want to the whole time. So that's why these models have evolved. But also thinking about the kind of the money envelope, it may well be that some of that funding can be used to support some of these additional models as well moving forward.
I suppose that's part of the need for a good implementation window when we start looking into this. And David, I understand there's been discussions about that implementation window, which was originally scheduled for 2022.
That's right, and I think this is where COVID has come in, and obviously it's occupied a lot of headspace and time, clinicians' time, both in the college and also in the NHS employers and things. So I think we're very keen to carry on with a submission to the GMC, because if we can get approval for the Progress Plus pathway, then we know exactly what we're dealing with it, and it will give us more time to plan that implementation and plan the transition. So originally, as you said, we planned it for August, September 2022, but now it will go to 2023. And of course, I was saying most of the effects in terms of workforce won't be apparent until 2026 onwards, but that time goes very quickly. And I think when you're planning changes in service and possibly using other health professionals or using your budget differently and rearranging your programs, then you really start having to think about that fairly soon, really.
That's really helpful, thank you. That's the end of my set questions, but I wondered if there was anything else that either of you wanted to add before I call the webinar to a close.
I just think it's a really exciting time for paediatrics. I think, these changes should hopefully be very influential and improve training, and we can retain doctors better in paediatrics, which can only be good for children's health outcomes.
Yes, and I think that, as you said, the feedback from the trainees has been very positive. And I think trainees have a very good idea about how they want to train, in terms of if you can make it more flexible so people can have individualized training pathways or more choice about the training, then that's to everybody's advantage, including the patients, really.
I'm sure that's very true. Fantastic. Well, we wanted to keep this relatively brief and focused, and we've reached the end of our questions and time for today. So I just wanted to say thank you both for giving up your time and your knowledge to this webinar. And I'm personally looking very much forward to this being the start of an information exchange that will go through the consultation and through that implementation phase that we just mentioned. So thanks to everyone that will be watching this, and we look forward to having a conversation with you too. Goodbye, everyone.
Thanks.